Welcome to the Soft Network podcast. I'm your host, Chris Ostrander. If you're new to Soft Network, we've actually recorded an entire video on why we're creating a podcast, what we aim to do with it. And just for a quick recap, we really want to promote these opportunities to have a conversation to help clients, help our clinicians, promote our clinicians, and then really support the SOF in the veteran community. But you can watch that. There's an entire video. Put a link in the bottom in the show notes. If you're new to Soft Network, quick recap. We're a national nonprofit that serves the special operations community in three distinct ways. First, we've got a national clinical directory. So it's a directory of licensed mental health clinicians that specialize in serving the SOF community. Many of them serve veterans, first responders as well, as you'll see in our discussion today with Adrian. He works a lot with first responders here in Florida. But if you're from the SOF community, or you're just a veteran or a first responder and you're looking for a really great clinician, please check out our directory. The second pillar of Soft Network is our pipeline program. This is devoted to members of the special operations community and or their spouses that are leaving the community, or maybe their spouse is still in, but they're pursuing a graduate degree in clinical mental health. Could be social work, marriage and family therapy, licensed counselors, psychologists, etc. And we pair them with one of our fully licensed clinicians and help mentor them as they move through school. And then our last pillar is clinical research. Given that this population is unique and there's not a lot of access points for good research, we really wanted to create a database, but also our own research team is working on some research as well. So feel free, you can check us out. It's just softnetwork.org. Real quick before we begin, if you would please subscribe to the channel. It doesn't help me as an individual. This is connected to Soft Network, our nonprofit. And so as we aim to grow this resource, it's really aimed at supporting you, the viewer, if you're a veteran, member of the SOF community, a clinician that just wants to learn more, somebody that just wants to support. But as we grow this is ultimately just going to feed right back into Soft Network and the mission that we serve there. And so please do us a favor and subscribe. It doesn't cost you anything. You'll just get a notification whenever we pop another video up. Okay, today's guest is Adrian Marquez. Sorry, let me get situated. He's a former... Well, let me just introduce him. Adrian Marquez brings a unique perspective to the field of psychotherapy. Before transitioning to mental health counseling, Adrian spent 16 years in the Marine Corps. He served as a recon, Force Recon, and Marine Raider before compounding combat injuries led to medical retirement. During his time in service, he was trained as a scout sniper, combat diver, military freefall, master breacher, as well as many other unique advanced special operation courses. He also graduated the Joint Special Operations Forces Senior Enlisted Academy. During his military career, Adrian served as a Force Reconnaissance team leader and Marine Raider team chief. During his career, he had the opportunity to fulfill other non-traditional roles under Special Operations Command. He participated in large operations like Phantom Fury, the capture of Fallujah, and deployed several times with small special operation teams across Afghanistan as a Marine Raider. Combat-related injuries awarded him a Purple Heart and led him to transition careers. During his transition and while working on his own mental health struggles, he felt the call to help others strive towards wellness by pursuing a career in counseling. While finishing graduate school, Adrian worked with NASA and the DoD as a senior engineer filling the astronaut rescue and personnel recovery desk within the rescue section of the DoD's Human Space Flight Recovery Program. Once he achieved licensure, Adrian transitioned into the field of mental health counseling. Within this career, Adrian has served as an individual therapist, program manager, clinical director, executive director, and corporate director roles. While working within private practices, Adrian was led to create the Sheepdog Program Corporation, 501(c) that focuses on veterans and first responders. Adrian currently serves as the program CEO. The Sheepdog Program offers a dynamically different and uniquely tailored approach in treating veterans and first responders. The program takes a fresh fresh approach in addressing PTSD, moral injury, reintegration, anxiety, and other disorders associated with these careers. Adrian is a co-owner and partner of Emerald Medical LLC, where he also serves as the director of behavioral health. Emerald Medical LLC offers full medical and behavioral health services to the local community. Adrian is a Jungian-oriented therapist that holds an EMDR certification. Adrian also specializes in providing virtual reality exposure therapy, biofeedback-based meditation, and psychotropic assisted counseling. Adrian was one of the first providers here in Florida that joined the SOF network. I've been able to get to know him over the last couple of years that we've been in existence. And so as our first guest, I wanted to bring a former operator, turned licensed clinician that can really speak both languages. If you're interested in learning more about Adrian, again, I'll put all of his links, including to his sheepdog program and his practice, in the show notes as well, so that if any of you are in Florida or just interested in wanting to connect or learn more about Adrian, you can do that. All right. Really thankful for you guys to take this opportunity to watch this. Hopefully you pick up something and learn. Please like, share, comment, subscribe. But here we go. Episode 1, Adrian Marquez.
It is what it is. We got to work it, man.
Yeah.
I mean, come on, we're not exactly young anymore. Like, for us to be able to figure some of this technology stuff out, like, that's a win. Just take the W on that one. Like,
take the W. It's officially 22 after, and we're in. So we're rolling.
Yeah.
Dude, I appreciate you jumping on, first and foremost. So much to talk about. I've been thinking about it the last 24 hours. Well, for probably a couple of years now, but intensely the last 24 hours. And I think one of the things that I came up with was starting SOF Network, where one of the things that I wanted to straddle was, how do you serve the clinician and how do you serve the community at the same time? It's got to be a resource for both if it's done right, in my opinion. And so approaching, a podcast and having conversations with providers that are from the SOF community, I was like processing that, thinking about that. I mean, waking up in the middle of the night, even last night, and I think it hit me of just, I want it to be a resource. So I want to talk about the things that matter to you, and I want to talk to you and get the insights that you have that the typical clinician and or, guys that are still in, wives that are trying to gain information for their husband, etc. Like, what are the most important things on your heart and mind that you think need to be discussed that maybe aren't being discussed?
Yeah. I mean, there's a lot to chip into. That's a giant iceberg of like different topics to lean into on that space. So, I mean, where would you like to start, I guess? Like, which part of that you want to start on?
Well, what's most important to you right now?
Let's go from the angle of the clinician side, because the first thing to kind of throw out there is like, if we're talking to the clinicians, is like there was a lot of rigidity. There's a lot of rigidity in thought process. After I came out of the Marine Corps, I was a part of a lot of veterans organizations and like working with nonprofits. And I'm sitting there talking to psychologists, therapists, and while I'm trying to provide my reflections, they're like, well, I've been working with special operation guys for like 6 years now. So I've got a pretty good handle. Like, oh, you've been working with them for 6 years. That's great. I was that person for 2 decades. Like, it's kind of, okay, fine. Be like that. Just sit there. I'll be right back. And they go to grad school and like go through their hard gates. So now I'm sitting on the other side of the table. And then all of a sudden, it's like, we're going to listen to what you say now. It's like, my opinion hasn't changed much. Like, I have more empirical evidence and understanding of some of the systems in place, but like the direct way of trying to approach things, the thing to try to bring to their attention. A lot of clinicians get trained and get stuck in the rut of their training. And it's really hard for them to break frame, but you can't experience insight unless you're willing to break frame. Something new can't come in unless something old is willing to die. Like, so you have to be willing to be in that posture.
I'm also curious, as you're saying that, I mean, we could never know for sure, but how many clinicians working with this population right? Like you were mentioning that clinician that you're working with, that it's almost like an ego thing of, well, I've worked with this population. I know this population, as opposed to staying flexible, because there's almost this need to prove themselves or, be in a position of authority. I don't know if that's the vibe you got, but I'm just curious if you see individuals working with this community that struggle with that.
Oh, absolutely. I mean, this goes in so many different spaces. It's like that sense of self-efficacy, which we all have to some degree. You got to become comfortable with that and learn how to surf that properly. But I do think that there's, I, I have to be the superior. I have to have like the alpha mindset. I have to have the top idea in the room, and struggle with humility and recognize. I mean, we talk about like what's something to kind of give clinicians to kind of recognize, especially working with veterans of this community, PTSD. Like one of the ones that I've spoken on quite a few times, gone out and like done lectures on as well too, is it's it's not just your checklist. I mean, you have the diagnostic criteria for this disorder or that disorder, and you can kind of recognize um, that there's going to be a certain aversion to certain type of triggers. But as a team chief, as an assault force commander, as like a team guy going through the house, I know how to clear the room. I've done huts, done it in real life, done it in training. Like being able to check the room, see how many bad guys we have, do clear their bodies. Like we practice that plenty of times. We've rehearsed that. We can go back to that easily. But never once did we even brought role players in from like Ethiopia, from other countries, so that we'd have a different dialect and they'd live in this village and we'd do operations there. So we'd have this cultural division to kind of help us get familiar with it. But never once when I was doing, SSE or doing huts at the end of a raid, like that's when, like, like I said, you sweep the room and you kind of tally up your numbers to report at the higher. Never once did I have to practice that on a 12 or 13-year-old boy.
Mm.
That might be what you're actually dealing with over there, right? So like it's the extenuating circumstances that are so different. We would go through a raid and training, and then we'd come back, and even like the time we had those Ethiopian role players, they would wail and they would moan and they would scream, like they're frustrated or upset because something's happening in their village. But when you hear the actual crying of a mother who just lost her husband or just lost her son, like that resonates differently. It just hits you at a different octave. And those are the pieces that when you see certain things, it will. I mean, there's a movie, Pan's Labyrinth. Not, it's an interesting. It's a very creative movie, right? But at the end of it, the main bad guy, he gets shot like right in the face, and very very the director or whoever was doing the visuals had this interesting effect where like there was almost like a ripple effect underneath of the skin as it like went through, and it looked so real that a lay person would look at that and just be like, "Oh, that might be gross," or like, "Whoa," right? But a person who's actually seen that before is like, "Oh, that hit different." Like that hit different because I've seen that happen in the real world. So the extenuating circumstances. You're treating a person with PTSD. You want to go. They want to go back very often to like, well, this is criterion A, so let's go back to criterion A and like hammer it and hammer it and hammer it. Like look around that a little bit. Like what are the weird things? If you really want to find the cues that are triggering a person, look around that. What are the weird little nuanced details that a person can't train for? I was a special operations guy. Like if we deployed and didn't get into it, I would be really, really pissed. I was a scout sniper. And I was a recon, Force Recon Marine. Like if we spent all this time away from our family training and we went overseas and we didn't get into the mix, I'd be really annoyed because I spent all that time as a young kid, like getting ready for that, doing that. And we're in a season of war. It wasn't that sniper mission or that guy that we took out. Like I might have been a part of putting that target package together to get him cleared hot. It's the weird little nuanced details that I didn't have the training and the preparation for. You can't prepare for it like that. You can use moulage and different types of things, but when you see what the inside of a person's skull looks like, because a 50 cal is just straight cleave them up, like you're not supposed to see that. It's just not something that we're meant to see, and it'll stick with you. It'll imprint in. Um, treating that PTSD, learning how to find the moral injury. Like you have trauma, there's experience of intense suffering that overwhelms a person's capacity to cope, right? And there's tons of trauma, but the reason why PTSD is such a different one, right? Because it meets the criterion, it's trauma, but it meets this specific criterion because these criterion also have a moral injury paired with it as well too. And learning like I have a virtual reality headset here. We do different types of software programs. I got a whole combat simulation program that I use with the guys, and like anesthetizing them to the booms and the bangs and the noises. That part's easy. I mean, like it's something you have to continue to make sure that you have a conditioning towards. That's not the hard part. The fact that some clinicians don't even fully understand how to attend to a moral injury, that's the that's the foundational belief system that's been ripped away from that person,
Hmm.
that they've had stolen from them, and that they're really afraid of having in violation or being breached again, and learning how to direct them to attend to that.
I want to go back to something.
Yeah.
I want to continue the moral injury thing, but I was just thinking about you being in both worlds. How much of you mentioned, you guys doing training workups, you've got, different compounds that you guys train on, you bring in foreign nationals, etc., to be role players. But you mentioned there's certain things that you just can't prepare for. Could be the octave of the scream, of the cry, could be the kid, etc. Right?
Mm-hmm.
What, if any, prepares you, or does the military help prepare you at all? Does the team prepare you at all, like older guys, for those nuances that you're not going to see in training?
So it has gotten better. Remember, I'm the weird generation where I joined the Marine Corps before 9/11. So when the towers fell, when all the deployments started, my seniors, my elders had not been to combat. Like very few Gulf War people around. There was a huge void in that middle leadership. Like I had been in for 2 years when the towers fell. I was just promoted meritoriously to corporal, and when they started deploying everybody, like normally back then, especially in the Marine Corps, like to make it to sergeant, like being a corporal at two years was rare, because it was not normal. Like 2.5 or 2 years, 8 months or something is when you're now just eligible for sergeant. But it would take you normally years to get sergeant, especially like before the wartime. There was such an exodus of people between like sergeant to gunnery sergeant at that point in time. Like they'd been in forever. Like there hasn't been combat. That the day I was eligible for sergeant, I pick up sergeant, and now I'm like, going to a recon, to the recon school, and then going to deploy with recon, and I've only been in the Marine Corps for like 2 years and 8 months. And then there we are in like Fallujah. That's our first deployment that we went to, and I got these young kids that are like, "What are we gonna do, Sergeant?" I'm like, "Bro, I got no idea, dude. Honestly, to be truthful, I only got here like 2.5 years before you, so like, let's just figure this out together. Like, we're gonna do the best we can, you know." So our seniors, they were they were still training, and some of our gear was still Vietnam War era gear. We're bringing new stuff to them, and they're like, "You don't need that. We've always trained with this stuff. Like, but you haven't done this job yet." So now the younger guys are going out there and they're doing it, and they're still coming back, and we're still younger guys. We still have seniors, but the seniors are not doing what we're doing. They're sitting in the operations shop. They're sitting in the higher level. So we're coming back like, we could use this kit. We could use this gear. We could use this help. Like, we've never needed that before. Like, you've never done this before. So it took a while for that to start to catch up. It took a while for those guys to age out, to leave, and then the mid guys and the younger guys to start to fill in some of those gaps. I think it started to get better. I've experienced some of it getting better when I was still in. But there's certain things that training and the preparation and the rehearsal of things, like the you're well aware of this with like trauma, but the reason why we do so many reactionary drills, so many rehearsals and practices, is because your mind is going to have your ego has no choice but to allow certain details of the event that you're experiencing to come into awareness, like into your understanding. I have to repeat these things so often. I'm going to be exposed to these things. Like there's no prevention of that, right? But how I feel about those things, like to have what I've seen and the details, the raw data of what I've experienced connect to how does that make me feel. There's very few processes in place that have allowed that fusion to happen. Because as soon as that's done, I mean, you can be on a deployment and you can lose somebody in your team. And I've sadly seen this where they have to pick up the pieces of somebody, they're putting it in a body bag, and they still end up driving around with that body bag in their vehicles for a couple of days before they can even bring it back. And when they bring it back, they're just sent right back out again to continue to operate. So like, you don't, I have to pay attention to what's before me. Cops and law enforcement. I finish that call, seeing whatever I see, suspicious smell, baby floating in a pool, like, things that they're going to leave you with some kind of a feels, right? You attend to it the way that you have to attend to it because I am a representative, or I am here for a specific purpose. and I don't have time to let myself sit. How does Adrian, how does this individual feel about that thing? It's not even my situation, maybe it's somebody else's situation, but you still have a right to recognize that it makes you feel a certain thing. And let yourself experience that so you can have that fusion of those two and your mind can attend to it. When you don't, that's when the acute stress disorder of experiencing a trauma starts to shift into that PTSD, because whenever something reminds me of these raw nerve endings of the details of things, or I start to feel the unconfirmed, undefined feelings that it made me feel, they're just sitting in my unconscious. I don't like that. I don't like that. I don't know where these things go. And so I have some kind of an avoidance response to that. I'll get angry, or I'm drinking it away, or I'm just trying to not be there, disassociate. I shut down. I don't want to be with this thing that's causing me to feel this unresolved, unconnected confusion. So I want to keep pushing it away. That's one of the things that we try to do with police departments now, and like some of the and a lot of the veterans that I work with, is try to give them immediate, like as close to the X as we can, connection of those two, so that they can digest it and process that. Or sometimes you get to the hard digging and excavate those feelings that have been long since forgotten, or they haven't had a chance. Because as time and space grows, the details of the event start to warp and shift inside of my mind. And what I believe I felt for them start to change a little bit as well too. So it might be a little harder work as more time that we put between the two and bring the two together again.
You mentioned, sorry, so much that I wanted to jump off on, but I want to let you finish. So I've heard this before, but obviously when a military force goes into a new theater, if they haven't been at war in that area, they're going to have new or old equipment, and they're going to have to, develop the new equipment, so on and so forth. I'm curious, as that relates to counseling, right? So there's just a flood of veterans out there, a flood of first responders. Having lived in both worlds, what do you think is maybe being developed, in the process of being developed, that is going to be the wave of the future, or you think is going to be impactful, something that maybe you're using or other people are using, but I'll say the greater population of clinicians really needs to start to learn about and potentially start playing with?
Yeah, that's good. And dude, don't hesitate to interrupt me if I start getting on my
No, you're
tangents.
good.
just put me in park and like let's whatever questions. Um, I'm a big getting into technology, understanding what's available out there. But when you do that, there's also a lot of snake oil salesmen out there like this doohickey is going to do amazing things, and it's pretty much like, isn't that a Fitbit? Like it's the same thing that like, most of us wear, like most smartwatches do. Like why would I? But virtual reality exposure therapy, I think, is a very powerful tool. There's some guys that have put some great software out there for law enforcement, for military, and built it up really well. Like I have a 4.5 by 4.5 foot pad with 4 subwoofers underneath of it, like attached to the bottom of this station. The VR software goes on your head. You got the handles, and for the combat simulators, like when
Are they
I
standing?
trigger, they can stand, they can be sitting. I mean, depending on the scenario, if they're driving, I have it set up like a lot of great controls. There's one program called Brave Minds, really great. Skip Rizzo and his guys put it together. It's he could be sitting, they could be standing, they could be on patrol, they could be moving, and you can and the clinicians sitting here, and we have controls over like a lot of different things, like how far the explosion was, what type of an explosion, the sounds of aircraft, the time of day, are you under MVGs? Like we can control a lot of those things right here. So I'll work with the guy. He'll tell me his story. We'll find the scenario that best fits his scenario, so we can put him as close as we can back into that space, and we can really work on allowing them, after we've done some emotional regulation and body mapping techniques, so they can start to learn how their body carries things. We can let them experience that and try to bring those pieces back together and do that excavation. So like there's some really great tools that help you get there. And some of these guys that are just calloused or just not receptive to EMDR and some of these other processes, once you do something like this, they start to feel it again, and you can be there. I had one gal, she was getting diagnosed with like the seizure disorder. And as we did some of this training, some of this work, she was just having such an intense disassociative reaction to these stimuli that she was just shutting down. Like everything was just powering off inside of that space. And being there and being able to talk her through it, like, okay, at this point in time, I'm about to trigger that explosion that you mentioned happened about 10 feet off to your right. Are you ready for it? She's like, she's ready for it. It would happen. She's prepared for it. So she's like, experiencing it. You start to see her shut down. We could talk. I could talk her through some grounding techniques. She'd be able to ground herself, and she would be able to learn how to compose herself through these environmental stimuli that used to be so automatically just causing her body to shut down. The second one, psychedelics. Like, I think people are, especially clinicians. I have psychiatrists that are still angry that marijuana has been legalized in certain states. And they're like, they're wanting to kick people out of program because they're like, he smokes the devil's grass. I'm like, it's a medicine now. Like, he has a prescription for it. So figure it out. Like, figure out how this fits. Like, you're taking control of his medical, figure out what's his dosing and how he's going to use it. But it's there. It's here now. Get ahead of the times. Clinicians have been indoctrinated, and not just them, society was indoctrinated for so long that it's such a bad thing. It's such a bad substance that it's a doorway for demons, and it's just evil. Only those people that listen to Megadeth and do the acid should be doing psychedelics. But it's a medicine. I mean, we can look back and see that it's an ancient sacrament that certain tribes have used for thousands of years, and the effects of it, and we can recognize the compounds that they are, how those compounds affected it, like the neuropsychiatry of it, like how it's physiologically affecting and attending to the body. It's not a mystery to that extent anymore. And the way that it just helps us, like, we know that the mind has control over the brain for the greater part. It used to be like, here's your brain, the old materialist view, right? Like, here's your brain. You got it. You're going to mess it up a lot during life. And like, as you mess it up, your capacities just shrink and shrink. Now with neurogenics and other understandings, we realize that your mind, like the capacity and the direction of your thought that you choose to put focus and emphasis on, can create, enhance new directions, new neural pathways within the brain. Even when your brain is damaged, the way that you attend to that, like, your mind can map around said damage for a greater part. And so the mind has this great, so as your mind's creating these incredible neural pathways and, helping you to see things from such a, I mean, the psychotropics is a great discussion to get into, but so much that we can pull from that as well too. So yeah, those would be my two: understanding the scientific tools that are out there, like virtual reality exposure therapy and psychedelics. I think are two great tools for not just veterans, but for I mean, I have people that are afraid of airplanes, afraid of MRI machines, and you can use virtual reality exposure therapy to help with that.
Yeah, I think one of the things, so psychedelics is such an interesting topic. I think that one of the things that I've at least discussed with people in my circles that are opposed to it is similar to the VR. At the end of the day, all good therapy is built on exposure therapy. We may not know everything about psychedelics. It may not be being administered effectively, ethically. Like there's with it not being legalized, there's just a lot that still needs to be cleaned up in the wash. Mm-hmm. But at the end of the day, and you know this better than I do, we could talk about this. I'd love to hear your perspective. But at the end of the day, it is exposure therapy. But unlike the VR, when you're talking to the lady and saying, hey, I'm about to trigger that explosive 10 feet off or 10 yards off on your right, it's pretty much out of control to a certain extent.
Sure. I mean, I completely agree with you. And that's why I think it's here. Like, psychedelics are here, like in our clinic that I'm a partner at down south from where I'm at here, like it's ketamine therapy, and that can be given as a medical treatment, at a medical center with proper oversight, and it's a rapidly rising treatment for anxiety disorders, suicidality, depression, and resolution of trauma. Ketamine therapy to me is like, out of the psychotropic therapies, it's like the special operation raid of psychedelics. It's like, get in, get on, get off, get out, good night. That's what we kind of say when we're going out there.
You think, well, I mean, part of the interest, or, well, let's just educate. So ketamine, for most people that don't understand, you can turn it up and turn it down. Now, experientially, I haven't experienced ketamine. I'm curious, have you? Because I got a follow-up question if you have.
Mm-hmm. I have, yeah. And you can come down to our clinic, man. We'll get you started.
That process, if they go, let's say they go too deep, or they're too far involved in the medication, what are some signs for individuals that are potentially seeking ketamine therapy? What are questions that they need to know, things that they should probably screen a clinic before they run in there as a first responder, as a veteran? what should they know about ketamine therapy?
Oh yeah, I mean for all of the psychedelic therapies, like in our clinic, we will not provide ketamine therapy unless you're doing it in this whole behavioral health package. Like sadly, there's too many like pop up ketamine facilities that are just like, come on in, like lay down, strap you in, like and help a person through. But you're there is a benefit to having the ketamine that like break down into its metabolites, have the increase of neural activity, I don't want to get too off track on it. There's a benefit to that, but you're missing so much of the importance of the work, what's being done. Understanding psychotropics are basically shadow work strapped to the nose cone of a psychedelic rocket, right? So like being able to recognize these images and these symbols and the interplay and helping that person understand this communication channel between his conscious and his subconscious mind. Because this medicine, as it breaks down, is going to help them go from alpha wave, or sorry, from beta wave all the way down to the theta wave, where they're going to have these subconscious these images, just like they're dreaming. The best way that they can explain it is that you're consciously participating in the subconscious process of dreaming on a very visceral level. But having a screening beforehand as well too, because obviously if any kind of like fracture of psyche, the psychotropics is not a tool for you to use. And I've heard of and caught down the road like people who have been able to go down that path and seen the fracture get worse because they were not properly screened beforehand. So like any of the schizo type disorders, that's definitely a cutout. Bipolar is another one where you got to be very wise on, especially if it's one or two, and depending on what's going on, it's still possible, but having a very healthy safety plan in place, because as they have this reduction of their HPA axis activity, they could lean towards a more like I feel great, like a more hypomanic or a manic type of a state, and it might require, depending on how intense those negative symptoms have been, it might still be a great modality, but just have a safety plan in place. Like we're just going to agree that you're going to give your partner the credit cards for the week after we do this therapy. So you can help to attend to those suicidal thoughts and bring you to a better space and keep leaning in on the work. And then some people would argue back and forth about personality disorders, but I think that if you do the right, and all of it, the right preparatory work is key. Like being able to help a person recognize what they're experiencing, why their mind is bringing them these concepts, how to best attend to these spaces is the most important part. They're going to get the most work done. And they're going to, and I think the people with the personality disorders, it's one of the most beneficial things to them too.
So let's talk about that for a second. So first question, is the preparation work for ketamine the same as, let's say, ayahuasca or 5-MeO DMT? What's your perspective on that?
In many effects, it can be. There's a space where each medicine is going to affect the person differently. Like ketamine is an anesthetic, analgesic medicine, so like the body has this opportunity to go numb, like to relax it. You can still find all of yourself if you're looking for it, but you can also lay very still and have this incredible disassociative experience where you forget where you parked your body. You you can have that similarly in some of these other psychotropics, but your body is a huge player in the game. Like ayahuasca, for example, where you're going to have this like intense unwinding feeling in all these parts of your body, DNA like splitting apart and falling apart, and like the purge building up inside of you is going to have such a physiological effect as well too, that you have to understand that that's going to be different. What will be similar is understanding how you're understanding just your mind. Your mind loves you. It's a part of you. It loves you and it wants to heal from all of these wounded and broken mental and emotional dilemmas that it's experienced. And it wants to work with you through this process, and learning how your conscious mind and the ego interplay with each other, and how the ego blocks a lot of subconscious process from being able to be attended to. Like the greater part of that iceberg, Freud's famous iceberg picture that's underneath of the water, right? It's a huge part of your mind that wants to resolve things. It loves you and wants to help to try to work through these things. It's a part of me. I have to accept that my conscious mind's will might be flawed, biased, and the rest of my psyche has a good idea of what I have to attend to in that space. And to stop letting the ego stand in the way of blocking it. So in all of those psychedelics, that ego death, I don't like that term, but that ego death, I like to say like ego dissolution, is such a crucial component, because then the conscious mind and the subconscious mind can learn how to sit with each other. And even though they speak totally different language, and we'd use quantum grammar, syntax, and learn vocabulary because our frontal lobes taught that in school. Our subconscious mind uses symbols in this interesting interplay, like, interpretive dance therapy of, like, these different parts of our mind working with each other and letting them sit with one another and giving access to your subconscious mind, saying, hey, you remember this thing and how you feel it or experience it, or you contrive it in your mind as this intense emotional rush, and the conscious mind learning how to just sit and breathe with that and not to resist it, not to fight it. You want to work on that. And by just allowing yourself to experience it, you're just passing that file folder of trauma to your subconscious mind and letting them work on it. But your job is just keep sitting in that posture, because the medicine or the process is going to bring you the very next trauma, or the next issue that you need to deal with. It's like, okay, good. Thank you for that. Thank you for that. We're going to work on that. Hey, we also love to work on this thing. And you get, and without the ego saying, whoa, 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 no, we don't want to feel that. Like, get done in that. Let's get out of here. And having those reactions jump back into space that happen in your normal walk of life.
So I think there's a couple of things here. One, I think this idea that, okay, if the subconscious maybe speaks a different language, maybe it communicates with shapes, feeling shapes, experiences, etc. I think, and if I'm being transparent, but I would assume for clients, I've talked with some clients about this that, I've just brought in the idea of psychedelics. That seems very hard to get your hands around. Like, who's interpreting what and what does it mean? Let's say somebody, I won't throw you too big of a curveball, because I'd love an example, like, and I'll give you a little bit of time to think about it, but an example of a client that maybe went through ketamine or ayahuasca, or any of the other psychedelics that maybe processed something like that, where they were able, and like, how did the process work? How did they realize that the giant triangle that was trying to consume them, how did they connect those dots? I think the vagueness, the abstractness, the lack of detail in this, I think, is part of the struggle for a lot of people.
Yeah.
But the other thing that I think, and I said I'd give you time, so I'm kind of deviate just for a second. I heard you slip in this idea that, hey, the mind wants to heal itself. That's very EMDR. I'm curious, did you pick that up through your EMDR treatment? Because when I learned that through EMDR training, it really changed my perspective a lot. And for those that don't know, there's this idea that within EMDR that, if I cut myself, I don't have to tell myself, hey, heal that cut. The body and the mind automatically start producing that healing process. And so one of the foundational perspectives or ideas within EMDR is that ultimately the mind wants to heal trauma. It just needs to get back to that place to where it can finish those thoughts. And so I'm curious, for you, is that more of an EMDR thing that you're bringing into psychedelics just because you believe that about the human brain? Or is that more of something that you learned through psychedelics?
I mean, that thought is definitely one that's taught in EMDR, right? Like, so like the introduction of that thought was something that brought into EMDR, but I think it's just the experience of, I mean, one, I think it's the special operations guy in me. Like, you asked me about ketamine. Like, I would never encourage a person to do something that I haven't participated in myself. So, like, going through it personally and then having the privilege of working with a lot of people, sitting with them, being a clinical participant, like, sitting there, these different ceremonies that they've run, and like being there on behalf of, my clients that are going through it as well too. And like watching this process go, it's just something experienced, like truly experienced, that like your mind wants to have resolution, and the way, and the order in which people deal with stuff. I've had guys like, I want to get to that trauma. Why can't I get to that trauma? Like, I'm coming here, I've done this like, 4 or 5 times. And I just want to get to that ugly thing that I need to fight and deal with, right? That ugliness inside of me. But like, I just keep having all these journeys about love. And I like the love, great. The first time it was sweet, but just keeping love, love, love. Why? Well, what do you think you need after you deal with that trauma to rebuild everything? Like, your mind's going to serve you, have you attend to it in the steps that you need to attend to it. Like, you blast your understanding of the world and the relationships that you've had apart, you don't have the simple tools that you need to rebuild anything afterwards, if your mind is not going to set you up for that failure. And so many times I'll see the people get it in the order in which they need to get it, like this, or this is the terrifying thing that I know happened in my life, and I'm just afraid that I'm going to have to experience it. Time and time again, I see them never experience it until they're ready to experience it. If their mind hasn't, we're going to work on this, and we're going to work on this, and then we're going to work on this, and then inevitably they'll be, or not inevitably, sometimes by the time they get there, they don't have to go directly there. But when they do, like their mind has prepared them for it. At the same time, there's also that, like, it tried to bring me somewhere. It's like, if you come from the same orientation that your mind loves you and is trying to heal, remember, it's the larger part of the iceberg. You might not think you're ready for it. Your conscious mind, like, you might not think you're ready for it. You might not feel like you're ready to go there, but it's your own self saying, hey, I am you. You are we. Together we're the I. We're ready for this. Like, we can, like, and I got this. Like, I'm ready to take this. You don't have to keep it trying to compartmentalize up there in your mind anymore. Just give it to us and let us start working on it. Let us start resolving these things. All we need to do is, like, I shouldn't say all, like, psychedelics is a fun wormhole to get down. But like, if you can get yourself past that ego disillusion and not resist allowing yourself to experience, like, you see that people are like, I don't want to relive that thing again. Like, you don't have to necessarily relive that thing again. It's just the symbol, the living encounter that we have with this memory brings back all the memories and the emotions and the feelings that happened before, during, and after, in like this in this moment. So it's as if it's almost experienced as if, like, I've relived it, not necessarily relived it, but experienced, like, as long as I don't let my ego back on board that tries to, whoa, we're not going there. We're not going to let ourselves feel that way again. And it wants to protect us, but it's been at our detriment, because by never letting myself experience that, I haven't been able to figure out, I mean, how do I feel about some of those things? Like, let me put those pieces together, those raw nerve endings together, and let myself finally digest and process them. Does that make sense?
Yeah, my mind is going in 10 different places all at one time.
Do you want me to hit the first part of that? Because I mean, the first part of the question, I know I kind of get long-winded sometimes, but with what people experience, like I said, it's here. Psychedelics are here, and the reason why they've lasted so long in these different groups and communities is because they're effective. But like, I attend to it using a lot of, like, Jungian dream analytics, and like looking at the collective unconscious and like these different components of that, and recognizing, like, when I do the prep work, I do a timeline with them very similar to EMDR. I get a lot of individual unconscious elements in there as well too. So if there's a competition between collective and individual, I know which direction to lean in as well. But a lot of dream analytics, and when you're doing that and you're working with the person, I tell them, I'm not the decider of what you're feeling. Like, I'm going to talk about some things, I'll say some things, and let me know how they resonate with you. If they feel like you're missing the mark, that's fine. Tell me we're missing the mark, and we can reshift directions. But a lot of times as you're talking about stuff, you'll see them be like, yeah, I think that absolutely does have to do with, that thing that happened in my teenage years. But we have to step into that gap, because there's been a lot of people that are working in those other spaces, and they're like, well, what this really means is that the ancient woodland spirits are trying to call you to surrender everything you have and go move out to the woods and live naked out there. I'm like, I mean, I've heard the most bizarre things from, the spiritual coaches, the transcendental light coaches, and, like, I mean, I'm not trying to knock some great people that I know that are in that space, but there's also a lot of people that mean well, but don't recognize some of the potential harm that they're doing, because, like, they almost feel like, I will guide you through this, and I will tell you, no, what you saw, that this is what it means. Like, you're sitting at the center of the universe, and Mother Pachamama was feeding you from the bosom of her wisdom, and this is what she was really, and this is what she was doing. Like, or we could look at it more of a symbolic thing, like, the dude's mother abandoned him,
Right.
and we're talking about like a maternal wound in that space,
Yeah, I think this is one of the things. I think this exact conversation is something that is not being had, and it needs to be had, which is
Yeah.
the ethical knot that is psychedelics, specifically on the provider side. So to your point, there's research coming out monthly, if not quarterly, that's looking at psychedelics I gave a presentation this last year on the research boom in psychedelics and, you know, how long it's been around. It's been around for centuries upon centuries. But one of the things that I see as a counselor educator and also as a clinician is this, you know, intersection where you've got, it's been around for centuries and it's been taught whether through Native American practices with peyote or South American, Peruvian, indigenous people. And as Western people have gone down there, learned whether it's about ayahuasca, 5-MeO DMT, etc. In some places, there's this infusion, like you're talking about, of worldview. But
Yeah.
the more I've thought about it, this is a complicated matter because at the end of the day, if you as a Westerner, let's say you're a clinician or just an interesting individual, you go down to Peru and you learn this, technically this is a part of a religious ceremony, right?
Mm-hmm.
And so you've got the multicultural component to it. And so you can learn it from that. But then when you come back to the United States and you say, hey, I'm a practitioner, I'm a coach, and you're trying to step into more of a medical space or behavioral space, now you're bringing in something that's technically more of a worldview and a religion than it is an actual practice.
Absolutely. Yeah.
And so, well, which is it? Because I would argue the more I think about it, it can be both. You know,
I agree with you. I think it's a great way to put it.
there's even individuals that have gamed, probably a better way of saying it, the legality of it by starting psychedelic churches. And so, hey, this is a church. But some of those same individuals are also the ones pushing into our space, you know, the license space, where they're saying, hey, this needs to be approved, this needs to be legal. And I think you're chasing two different pathways in that. I understand their heart in getting it into the United States and saying, hey, it should be legal. And so we found this loophole as a 501(c)(3) and, you know, we're a church. But at the same time, then you're going to have to wash some of that out if you're wanting to make it legal and actually have evidence-based, randomized, controlled trials, so on and so forth, to where the research actually flushes out, hey, does the medicine even work first and foremost? Which we're getting there. We don't know the long-term, some of the long-term effects in research. Some people would argue that. But then as a clinician, this is where you and I get super interested is, what are the clinicians actually doing and which therapies actually work best while they're under the influence?
Absolutely, yeah.
But then also during the integration phase, which is after treatment. Is it EMDR? Is it trauma-focused CBT? Is it more of just Rogerian, unconditional positive regard? What is it that works best with these compounds or these medicines? So this ethical piece, and sorry to hijack this a little bit, I think it's so important that if we're going to talk about it as a ceremony of these ancient people, then this is a religion, this is a worldview. If we're going to talk about it as a potential breakthrough treatment that the FDA and the VA need to get behind and really consider for post-traumatic stress, anxiety, depression, then those clinicians and those practitioners are going to look very different than over here. And I think there could be room for both.
I think there could be room for both too, man. That's a great point. Like, we have a couple of obstacles, huge obstacles in that. It's the same thing with ketamine therapy. Ketamine therapy has been shown to be effective for a long time. Like, we recognize as this 20-year war started, that guys that were being treated with ketamine on the battlefield were less likely to develop PTSD. And as they started to dig that up, they started to recognize that the dissociative properties of it helped them just experience a naked observation of what had transpired, instead of, you know, being out of it, being knocked out of it, or, like, you know, being so emotional into it. Like, they could have a naked observation, a raw observation of what transpired, and they were less likely to develop PTSD. The big pharma did not like. I mean, this is my opinion on it. This is my Adrian's perspective on it. They did not like a treatment that in 6 sessions could help take away return customers, people that have been dealing with depression, dealing with anxiety. They have to keep coming back and getting more pills, more medication, more medication, more medication, more medication. So there's tons of resistance against it, even when, like, the American Medical Association, like, identified it as one of their, like, leading treatments for suicidality and anxiety in, like, the emergency room. tons of resistance, tons of resistance, tons of resistance, until Big Pharma came out with a microdosing version of ketamine that people can continue to take as a way of just giving them short-term relief for the bigger care. So it wasn't until they came out with a way of making it a tool, a medication that you have to keep coming back for, that they got insurance companies to start paying for it, because now it continues to feed into that cycle. If you
So
want to
they,
do 6,
sorry to cut you off. That's news to me. They actually have like take-home treatment microdoses of ketamine.
yeah, a lot of like the nasal sprays, and there's some of these troches as well
Okay.
too. Yeah, so but it's the dosing amount is a small percentage of what you'd get. Like in our clinic, we'll do a 6-session protocol, 6 or 8 session protocol, depending on the person, depending on the situation. And for a lot of these individuals, when they're done, they're quite good. They're quite good from the anxiety, the chronic anxiety, the chronic depression. At most, they're coming back maybe like once in 6 months, and it's just and it's like a recentering, which I think there's nothing wrong with it. We have no problem saying, I'm like, hey Chris, why don't you meet me at Whiskey Barrel on Friday? We're gonna go tie one on, right? Like we'll plan going to get hammered
Right.
and deal with, like, we're old now, so deal with like the 4 days of recovery afterwards, right?
Maybe longer.
Yeah, but like going to the clinic and going for a 1-hour session where you feel recentered, refocused, you're reconnected with that, like, with your center. There's no hangover. There's no addictive properties when you do it clinically in that space. And I've had guys come in at 8:00 in the morning to get a session, and because they have a meeting at 10, and they'll be like, "Oh, it was one of the best days I had." Got the session done, came out, went to that meeting, and no anxiety, no stress in that space. Like I felt really centered going into it. Like it's a recentering versus versus an escape modality.
This is one of the things I'm most excited about, specifically for Soft Network. I can't remember who said this, so somebody can correct me on it, but I was listening to a podcast not too long ago, and they were talking about, when my grandparents, both my grandfathers served in World War II, when that greatest generation came back, they went to work, and so much changed about the United States, the economy, education. So many guys went back to school, etc. I firmly believe, just from the clinicians that are within our network, but also the ones that I've met, that some of them aren't in our network, but they participated in the last 20 years. I'll put the world and our greater society in America on the shelf, but I'll just talk about our domain and clinical mental health. I think you guys are going to transform it, and you guys are. I mean, I've seen just in the last 7 years, when my first client said, "Hey, I'm going to Mexico. You're either going to continue to be my clinician or not."
Yeah.
And that was my first introduction to psychedelics and scrambling to, make sure he was safe and all the different protocols and
Exactly. Yeah.
things he was doing. But that your guys' willingness to, and specifically special operations, but I would say veterans as a whole from the GWAT area, come back and realize, like, this isn't okay. And I'm sick of seeing people I know suffer. I'm sick of myself suffering, and they're they're going back to school, they're getting their education, or they're diving into, fill in the blank. It could be, hey, I just want to be a first responder because I just saw how crappy the world is. I want to keep cleaning up our backyard. But that idea of you guys pushing into these experimental, even though they've been around a while, treatments, and expanding them.
Thousands of years they've been, but experimental on the clinical side, for sure.
But the push to make them legal, the push to get them in front of Congress, legislation, the push to even do experimental studies with the VA, which they've done, your generation specifically, and more specifically, the special operations community. I don't think there could have been another group of individuals within the United States that could have made happen what's happened. And I know we're not across the finish line as far as legalities and all of that, but I think you guys are transforming the landscape of behavioral health, of medicine, in ways that, to your point, I think, some of the larger institutions, pharma, FDA, et cetera, are in the process of having to work with what you guys are continually showing as far as evidence, some of it anecdotal for sure, you know, a lot of people jump on podcasts. Oh, I went down to Mexico or went and did this ayahuasca retreat and I'm better. You know, we can't run up to Congress and say that. Like, there's got to be research, there's got to be evidence that's produced in journal articles, and you know, not just the veteran, but looking at that process from a 30,000 foot view. I think you guys are doing way more, and there's being a lot more accomplished than most people recognize. What we hear is, you know, the 22 a day or the 40 a day, whichever number you're going to go by, which is, you know, awful tragic. That's why you and me do what we do. But at the same time, some of the successes that you and I have seen and some of your partners and colleagues have seen within this space probably wouldn't have happened 10, 15 years ago.
I agree. Yeah, I completely agree with you, man. Like you brought up the great point earlier too, with the people that are, you know, skirting or gaming, like the way that the system's set up right now. That I think that's another reason for clinicians to lean into at least their understanding of the space, because there are a lot. I mean, there's places outside the U.S. and it's almost just. I mean, I guess I can say criminal that there's even governmental organizations funding nonprofits to send people outside of the country to go do this because they just want the plausible deniability that they're supporting, but they're sending them out of the country to be research participants in their studies to try to find just like. There's so many variables that you start throwing into your study when the person has to go through customs, fly somewhere else, get on a riverboat, go downstream, go to some place over, and then come back all the way as well too before you do the next TMS scan or whatever scan. Like versus being able to do it here. But even in the ones that they have that are stateside, like you bring like the concept is just as if just like, you know, it's illegal to give alcohol to a minor. So, but during communion, the Catholic Church can provide it to everybody that's signing up for it. You know, so they can offer it to the 14-year-old as a sacrament within their practice because they are organized that way. It's within their doctrine of organization that this is a sacrament that we use for our religious worship, and the government doesn't want to get in the way of religious worship. So you mentioned like 501c3 for people that are out there, and like for us to be aware of it as well too. A nonprofit can't provide this service. So they have to be in that church organization. It has to be specifically identified that these are the medicines that we are identifying as a sacrament in the spiritual process. And then you have one of two things. You have that church, like the one that I would support, or like I never push a person in that direction when they're interested in that direction. I should say I never. I've definitely absolutely brought it up to people before. But if a person wants to go in that direction, they tell me they're going to go in that direction, I will go with them when they go to one that I think is like a healthy space. If they're going to some like Wazoo place where it's too much of that mixed hybrid of undefined, you know, taboo and cultural, religious type of stuff mixed into it, and like, you know, they don't even know what they're purporting.
Right.
I'm like that's on you. I'll be here on this side, but I'm not going to go there. There's some places where they're like, this is a sacrament that's participated in these spiritual practices. We will provide the space for you to participate in the spiritual practice, but it's very come as you are. Like it's your faith, your walk. I'm not making you line up and take a flower petal bath or doing a smoke cleanse over top of you. Like we're not pushing anybody to like bring this practice is available for you to increase your spiritual journey. Like recognizing that importance. So they pretty much run it like a wellness clinic. And those same places, they'll bring actual medical professionals and actual clinical professionals, like therapeutic professionals, to be present. So like, you know, we're kind of like the paramedics at the rave. You know, like we're not throwing the party. We're like the safety team on that side too. So if a person's having a psychosis, if they have an unresolved like a buried memory come up to the surface as well too, they have a clinical team that has the skills to work with them in that altered state of consciousness, but just as importantly, right afterwards as well too. When they come out of it, I'm like, hey, it sounds like that was pretty heavy when you're ready to talk about it. And they can get that support in that space. And that organization is just providing an opportunity to participate in this practice versus some other spaces where, like you said, they don't have any of that defined. They don't have it fleshed out. And it's this weird hybrid of everybody, all these different coaches coming in and like whatever 2 cents great idea that they have throwing into it. And, that's dangerous. It's really dangerous. And us knowing the difference between those.
Yeah, I think for individuals that aren't aware of this space, one of the things that I would just say to help them understand, you've got this giant group of individuals that are highly traumatized from 20 years of war. And, you know, we could talk about first responders as well, traumatized daily. I got a couple of good friends that are cops. Some of the stuff that they deal with is pretty horrific. But you've got highly traumatized individuals, which makes them more suggestible. The research points to that. And then you've got this stampede. That's probably a little bit of an exaggeration, but just this huge rush into the psychedelic space. And with the lack of safety protocols, a lack of standards, you've got a mixed bag of snake oil salesmen. I mean, some of the clinics, people just don't understand. And I tell this to my students as well, as I mentioned that presentation. I went over this. You've got clinics where they're doing EKGs ahead of time. They're doing blood work ahead of time. They're titrating off medication. They're talking with the doctors. These are, I would say, much more sound clinics. They've got medical experts there in case there's a problem. There's clinicians there. And then you've got individuals that are flying to different parts of the country or traveling to different countries or even within the U.S. No real medical checks, no blood work, no heart check, no nothing. Hey, we're going to, drop you into ceremony. And then in the process, we're actually going to tell you how concerned Grandmother Earth is about.
That's exactly right, man.
You. And so now we're infusing this worldview. And as somebody that has been trained
in an altered state of consciousness, like while they're under
in an altered state of consciousness. And so I think as a clinician, but also as a counselor educator that trains and has been trained specifically on integration of faith and when to bracket faith. This is something that it drives me insane.
For sure.
You've got this highly influential population seeking treatment because
they want help.
They want help and they want it now. And so they're trying these emerging treatments, but some of the practices and clinics that are out there, highly suspect. And so, I'm just
and they still try to throw it in a guise too. They're like, oh, we have a medical professional like checking over you, and then you like see who the medical professional is. And I mean, again, not to attack anybody, but if you're gonna say a medical professional clearing people, I would expect it to be someone in the medical field that's clearing people, or someone in the therapeutic field, making sure that they're good on the mental health side. Some of the medical field, making sure that there's no medical contraindications. Not a dentist or a chiropractor or a light worker that's sitting there saying like, I'm the medical professional and I've cleared this person to go through it because they had a checklist that someone said these medications are like counterindicated. Like, no, you need to know why the medications don't work because it might be on something else or some other name of it, and like they have to have. You need to know how the person's presenting and what might be going on behind the scenes before you can say, yeah, I think you're cleared hot to go. We don't have training within that space.
Right.
And then that hybrid of mixing spirituality to introducing it. I mean, I have my beliefs, I have my faiths, and I will not, like, and I'm also a big believer that if we just keep all the roughest out of the way, like that person is going to find their spirituality. Like they're going to find, if someone's not saying like, oh, I'm really worried about the light entities that might be in the room right now, and like we have to burn this stuff all around you to make sure that they don't jump on your back. Like get all that ruckus out of the way. Like, they'll discover their spirituality. It's a real thing for all of us. However you want to do, I have different definitions. Some people, but it's a real thing for all of us. Just get it out of the way, and I would absolutely not introduce it to somebody in that space. That's not the place for it. Being able to give reflections to their experience from that. I mean, we talk about different cultures. A person gets trained in like Peru or Costa Rica or wherever they might go. Well, Carl Jung's talking about this collective unconscious recognition that these same images, same symbols, same avatars, same archetypes are showing up all over the world before there was social media, before there was these connections. Like, those are the themes of the collective unconsciousness that we're communicating from. They are worldly. Like they're something that's been across the world and coming up in all these spaces. So when a person says, I saw these owls. I stared deep into this cave, and as I was staring deep into this cave, these owls flew out, and the owls had golden eyes. Like that, and then the owls flew above me. The golden eyes like dropped, and as they dropped, my clothes lit into flames. Then my next task was like to pick up the coins, right? And then I turned and I walked in a different direction. You can attend to that with from a collective unconscious understanding of dream analytics. And the only real, I mean, the main cultural distinguishing factor would be like the owls, because in some cultures they're bad omens, and in some cultures they're good omens. But still flying out of the cavern, their eyes were gold, like picking them up, the recognition that most of the time fire is purifying, like phoenix kind of construct, like burning off of the old, entering into a new, unless the person's individual unconscious, like when they were a kid, they were stuck in a house fire, and then I saw that would then overarch the collective
Right.
unconscious state, versus someone who has none of that understanding of how to like apply those different perspectives on it, telling you what they think because they Googled it real quick. Dancing Star 2417 says like that's not what they need.
No, I'm always shocked. Sometimes it's students, sometimes it's past clients, sometimes it's current clients. Send me a bio of somebody that's a coach or a guide. I don't know what are the other names, and in it talks about that they're a trauma expert, and I'm always interested in, do they even know the criteria for PTSD? Are they aware of the history of the individual and some of those things? But I'm hopeful, as much as I'm poking holes in some of these areas that I think are really detrimental and are a slippery slope. I am hopeful, given what I've seen anecdotally and also what's trickling out in the research, and the interest that the government's getting into. Last year at SOCOM's Care Coalition, Andrew Wolfgang, he's doing research and working
Yeah.
at Walter Reed. He's active duty psychiatrist and actively, at a point where he's kind of tip of the spear with his team working on this, which is yielding, I think he just, him and his team published another paper on MDMA, I think in the fall, right before Christmas it came out.
Mm-hmm.
And so I say all that to say the government and, the larger entities are interested in it. I just think it's coming.
It's interesting that you bring that up, because we were there but just like missed each other at that last conference too, because our clinic got in touch with him, and like through conversations back and forth, because they're Bethesda, like Walter Reed, like they've assimilated a lot of our ketamine protocol that they're doing up there now as well too. So like our small little clinic working with these guys through that conference, meeting them, they've taken that. I mean, they probably modified it, but they were in connection with us, and they took a lot of that protocol up there to use as well too. Remember, the VA is its own entity, so the VA can get away with stuff that like the rest of the medical community can't get away with. And I wish that they had better, that, because the FDA has been slamming MDMA therapy, even despite the facts, despite a lot of the clinicians we work with have gone up to the VA training, and there's what he's been doing as well too, coming up with studies, like evidence that this is very effective. But for some reason, it keeps getting slammed down. That there's no benefits. There's no benefits. Clearly, there is. It's lasted for thousands of years. It's a great question as to why. I mean, why it doesn't make it through. I mean, I completely respect checks and making sure it's a good balance and it's coming from a reputable source, and I'm full agreement with all that. But also, not until it's at a small enough size that it becomes something of monetary value to us. I mean, our healthcare system is a business. I think we need to accept the reality. Like, healthcare is a business in a lot of ways. I mean, in every way, really. We have hearts of wanting to help and attend to people, but what drives the train? Like, they've conducted research on a medicine, and along the way discovered that this medicine completely cured symptoms of some other disorder. But there's so few people that have that disorder that we're not going to. It would not be beneficial to us as the company to try to put in the studies to prove evidentiary that these things work, so that we can try to get this passed as a medication for that disorder. There's so few people that have this disorder. We just kind of note it and keep on moving, and we're still working towards this bigger thing, because we want to have a catch at the end of this pursuit that's worth all this effort that we put into it. And meanwhile, you still have these people with this disorder that are like, wait, what did you say? Like, that could help us? Awesome. Like, when are we going to get that? Oh, you're not going to do the studies and the research to make this a prescribed medication for this treatment anymore. Business drives that. When we have these medicines that are clearly working, and there's always these roadblocks to stop it until we can get it a pharmacological brand of it that can be like, microdosed, or like, returned to us to get more of it. Like there's questions that got to be asked about that.
Yeah, the business has captured the institution of health.
Mm-hmm.
What do you think most veterans don't understand about clinical mental health?
I mean, there's stigma. I mean, there's stigma there still. I think the stigma has been getting better. But I think the first thing that most veterans mistaken is they think of it as it's an emergency room visit. It's like urgent care. These are a lot of, especially the special operation guys that we're talking about, a lot of veterans in whole. They understand going to the gym 3, 5, 7 times a week. Like they're all about maintaining the meat suit, like making sure that the meat suit is healthy, right? So like, how often are you going to the gym up here? Like if you, when you're in the gym, or if you want to run and get faster, if you're in the gym and you want to get stronger, like, you don't improve your run time by not running. You don't get stronger by like not attending to that weight. If you want to learn how to better deal with anxiety, if you want to learn how to better deal with those intrusive thoughts, like, I love when somebody shows up and they're like, I just want to deal with this anxiety. I'm like, cool. Like, we start working on a plan, and they think the plan is for us to do something magical where they'll never have to encounter like that anxiety again. I'm like, that's not how this works. Like, we can work on it and strengthening ourselves, preparing ourselves. But there's a space where we got to learn that when it shows up, like what we've been doing is trying to like run away from it, like trying to avoid it, trying to escape it. We got to learn how to embrace the suck, like to suffer well inside of that moment. But in that moment also, just like when I hit that weight that I can't lift, I have to learn how to start pushing against it, how to, the right way, with the right form, for the right outcomes, how to push against it. And then eventually that thing that was once overbearing to me starts to move easier, and easier. And then next thing you know, I'm lifting it, I'm moving past it, I'm able to attend to it without the discomfort. But a lot of guys will prefer to self-medicate, to drink, to give into other habits instead of learning how to sit still and sit with their breath and in their emotion, and how to push against that with effectiveness. So stop looking at it as like, marriage therapy. Like, I only go to that when my wife and I are at wit's end, and we start throwing the D word around, and like, we start like, you know what would probably have helped, like you guys sitting down and having a mediated conversation to improve what was once good. Like, if you're not taking the time to sit down and have the business meeting of this operation of, this enterprise of your marriage when things were healthy, like no confusion why it's in such a bad place right now.
It's so funny. I literally was working with a former Green Beret yesterday. And the topic of marriage therapy came up, and I could tell there was some resistance. Hey, what does that mean to you? And it was exactly that. It was, well, that means the marriage is failing, as opposed to looking at it like he works out every day. It's like, no, this, and I love the transition that, the DoD, and I would say the space as well, like cognitive performance, mental agility, like all these different buzzwords, getting the perspective shifted from this is when you're broken and you go, as opposed to this should be a part of the process really from day one, just like PT.
Oh yeah. Like that with the law enforcement contracts that we have, getting in the door with their new hire training, and getting at shift changes, and like them being able to see our team and that we're there for them. Like we provide, like, some of these departments an EAP alternative. We're in contract with the sheriff's department in certain places where their deputies can walk right into our door, their corrections officer, they can walk right into the door, get work with us, and the department covers their copay for the first set sessions, and then we do insurance for everything else. But and there's no concern of things being reported back. Like just like making it something that's so common that they can just come in and get help without having to feel like there's that stigma. Like, we don't talk about it, we don't deal with it. That's you're hitting the nail on the head, man. That's how too many guys think about it. It's when everything's like, you have a gym membership and you might be doing great and feeling really healthy and not go as often, but people are super resistant to continue to participate, even in quarterly marriage counseling, just as a check-in, but I'll tell you what, if you learn to participate in your marriage, and when there's something of conflict, like that is going to cause a conflict where we would be better off having a triad of conversation about this, like I can now take that, write it down, journal it, whatever, put it in a place where when we sit down with that counselor, we can talk about it in a healthy environment. It's not going to be like that. Sometimes you're doing that direct conversation with your partner. Like all I'm hearing is what I think you're saying about me. I'm not really listening to your words, but what that really means about me, right? And then you can have 3 great months and then sit down and have a conversation that there's some work that you need to do, but it can be how you guys can guide it and mediate it and continue to build the skills so that eventually that level of conversation you guys can handle on your own. And the next time something big comes, but it's also good to have the session where it's like, things have been going really good. Great. I mean, I love it when sadly not enough. Things are going really good. Great. How can we make good better? Like, what do we need? Like, what are you needing? What are you needing? Like, I didn't know that they needed that. Like, because you guys only come here when things are melting down all over the place. Right. Companies good spaces. But then they don't think that when life is falling apart and everything's awful, then they're going to want to do like 2 sessions a week for like this intensive, like month-long or 2-month-long type of a season of distress, that you could have avoided that if you just looked at it as routine care for your marriage, for your mind, and not just couples, individually too.
How do you think, I mean, you can speak to this from the special operations community, but how do you think veterans, first responders view us as clinicians? Obviously,
nerds. Yeah, I mean, I think there's the concern that I get it all the time. Like, I've done something that I'm afraid of getting in trouble for. That's a big one as well too. Like I was in a situation, I was in a space, and I'm afraid that if I tell you, I think it's the blessing of us being clinicians and having that legal and ethical protection. Like as long as you're not about to harm yourself, as long as you're not going to leave this place and take a baseball bat to Timmy's face, like we're good. Like, tell me about the bank you robbed in California last week. I'm going to be like, and how does that make you feel? Like you don't have to worry about us telling and reinforcing that. It's different, even different than lawyers to that regard. Yeah, that's my thought on that.
No, I think in setting up the network, this was one of the things encountering, and I met you pretty early on, but encountering all these individuals from the special operations community. Mm-hmm. And some of them not, but maybe had a first responder background and found themselves working with people in SOF. Is that those 2 questions are always on my mind. What do they perceive about us? And then what's their view of the process? Because I think those are barriers, obviously, that we can't control. Now we can package and get more individuals like yourself and people within our network visible to realize, like, hey, we're not all nerds. Some of us have unique backgrounds that literally come from the community or first responders. I think, again, this is where you all coming from the community and then going in and getting your graduate work done. And some of you have gone on and done PsyDs and PhDs, but getting your licenses and then working. Mm-hmm. I think you guys are changing the tide, not only of information, but also the perspective, because you can have conversations with individuals like at Hooks of Hope, our partners. I know you went down and, or you're going down, or you went down.
Yeah, I've met with them. It's interesting that one of the board members was my company commander for a pretty infamous MARSOC deployment that we were on together. And he's just a great human being. And they got me introduced to the group. And the next retreat that they're running in a couple of weeks, I'm going to go speak at.
Yeah. But my point, you can say things to those guys that go on that retreat that I could say, but it won't land the same way. And so I think this is what's so unique about you guys and the wives as well that are within our network, and those that are, it doesn't have to be specific to SOF network, but those people that have lived in a community, whether it's a first responder community, military community, SOF community, and now are clinicians, is you've got street cred, you've got an ability to step in and educate and teach these individuals things that, we're not all nerds. It's not all, sunshine and rainbows. Sometimes we may make fun of you. Sometimes we may, challenge you. You may be pissed at us after a couple sessions because it seemed like we were taking your wife's side, or, really pushing you to get over yourself and actually do the work. But I think your guys' message is critically important now more than ever, because of what you guys represent, and also the different communities that you guys have your feet straddled on in.
I appreciate that, man. I really do. Like, I think having a sense of authenticity, like a humility, humbleness when you're working with them as well too, especially with people that have. I mean, some guys come here, especially in my private practice, they'll come here and they'll be working with each other, and they just think I'm some weirdo with a beard and like a mohawk, and like a weird therapist, like a big, like a muscular therapist, kind of look like a Mr. T meets Mr. Rogers.
Oh, you're big. You're not a nerd.
Yeah, but and they're veterans themselves, and they don't know until like sometime down the road, and they decided to Google me or something that I was in the military. But being able to just be without obviously ever taking over the session as their session in that space, but like being able to recognize it, dude, yeah, that sucks. That's really like to be able to authentically empathize as a human, with them, that can they can just hear that you get where they're coming from without having to go, oh yeah, well, let me tell you my story. Like, you just hear that you get where they're coming from in that space. I think makes a big difference, especially when it's some of those, raw, nuanced details of just I call it the darkness. Like most people in life have the blessing where they see. Have you ever been to a pistol range? Like, it's a narrow lane. Like the target's right in front of you, and you have like a left and a right lateral limit, like right there in front of you with your target hanging in the center, right? And between that left and right lateral limit is the average person's, especially in the Western society, the average person's awareness of like the darkness and the violence and the savagery and the ugliness that's like out there. For those people that have been sheepdogs of society, like those left and right lateral limits continue to get stretched and opened and get broader and broader and broader, and they're more aware of just intense levels of the darkness, like all that rawness and violence and savagery, until they're like 360-degree fan fire. And when they understand that another person gets that ugliness, and the weird extenuating circumstances of it, and how it sits with you, and that it has had to wrestle with their own moral injury, great therapists out there, but some of them haven't really done anything in their life. You don't have to go get blown up, but it's like, but just are not very like they've spent their entire life sitting in a chair telling other people what's wrong with them, or and what's right, like what they could do, but like they haven't had the experience. I mean, they got to go out and they got to live. They have to participate in things. They have to fail. They have to win. They have to, they go through all those experiences, and then like bringing that into counseling, I think, is a very important part for us.
That visual reminded me of my good friend. I mentioned him a little bit ago. He's a cop, and he was we keep in pretty close contact. He was actually lamenting that exact same thing. He was like, I got two buddies from college, and he goes, they're worried about these stupid stuff. And he's like, in the back of my mind, they're yabbering. He was telling me about a conversation he was having with his friends there in his state. And in the back of his mind, he's like, dude, I almost shot somebody yesterday. He's like, you guys, you have no clue,
Yeah.
some of those parameters that I live in. And so then to come back for him, that was a huge struggle for him to come back and deal with, oh, Billy's cussing at Tommy on the playground. I'm like, what are you going to do as a parent? And he's living out in these margins.
Yeah.
It's something I think about pretty regularly for first responders as well as military members is how do we help them get back into, not that they'll ever leave the margins because they've lived there, they've experienced it and their mind goes there, but how do we help them integrate back into society in the sense of, as clinicians, how do we help them overcome, hey, not everybody's going to get you.
Whew. Like with like living in those more extreme spaces and like trying to help them recalibrate. Like, I, so here I am operating my meat suit. You know, you have your meat suit, and like, you know, this fictional, you know, Miss Higginbotham's over there. Like, she has her meat suit as well too, right? Like, the most intense thing I've ever experienced. Like, well, I'm still a human. I don't have some gamma radiation level of like, adrenaline to dump inside of myself. My HPA axis is the same as your HPA axis, same as her HPA axis, right? So, you know, the most intense moments that I'll like that I've ever experienced, be it like, you know, there I was, no shoot in the middle of Fallujah or northern Afghanistan or whatever, right? And her most intense uh, moment was when she saw the UPS truck accidentally run over her 17th kitten, Mr. Fluffy Bottoms, right? Like, her hypothalamus pituitary adrenal axis and my hypothalamus or HPA axis, right? They did the same thing. Like, our bodies experience the same chemical reaction and the pH balance, like were both affected. So while our environmental circumstances were objectively quite different, like our subjective experience was kind of similar in a lot of spaces. I think that's something that we, like, veterans mess up and clinicians mess up in that space, where it's not a measuring contest of like, you know, who
Mm.
had it worse. You know, they said we were doing subjective unit of distress scores, right? Like, it drives me nuts when a person's like, well, I mean, I'm not going to give that a 10 because Bobby over there has been through some stuff. I'm like, it's your subjective unit of distress in your life right now. You've had at least a 10, right? It has happened. And if we go through your whole timeline and there's no 10s on that timeline, like, what was your 10? Like,
Right.
whatever's an 8 now becomes your 10, and I have to like readjust everything, right? Like, I didn't have a more intense internalized experience than she did, but even though objectively you can say it now, at the same time, you know, she's my neighbor, let's say, and now we're all sitting together and we're going to my daughter's Christmas recital, and my daughter got to play Mary, and she was like holding this little baby doll, right? Like, and you know, like my mother and my wife and Miss Higginbotham's, they're all teary eyed because of how sweet this is, right? And I'm just sitting there like, I think she's gonna drop that baby. Like, I think she's like turning the head, like it's gonna pop off in her hands, you know. Like, I'm still human just as they are, but my environmental circumstances have been like are objectively again like stretched so much further. So I'm feeling intense emotions at this point when, you know, Miss Higginbotham's like objectively we'll say like smaller in that space. She has greater access to this different range of emotions than, you know, another person than one of us might have because we've been stretched out in that space.
Mm.
Now, I also think that will start to recalibrate at some point in time. Like, I've been out of the military for some time now, and I've been back home again, and I haven't had any experience like that for a long time, and in an optimal, non-challenge type of an environment. Like, you know, 8 years later, 10 years later, all of a sudden, my wife is able to scare the crap out of me. You know, she's like, she used to never get me. Like, I would hear her from like, you know, the other side of the house when she stood up, but now like she's like she loves scaring me because she get right up on me again, right? Like, I start to recalibrate, you know, how I'm attending to right now. But what never changes though is the memory I have of myself when I was at that different space.
Mm.
The way my mind recorded what I felt and what I went through at that point in time is the way that it was recorded. If it was traumatic, it was traumatic. I could have worked on it and attended to it. And those same situations, I have a whole different perspective on it. But you remind me of that moment, and the emotional memory associated with it is still the trauma that's in that
Mm.
space, right? So now here I am, and I'm recalibrating, and all of a sudden I'm watching, you know, This Is Us, or, you know, the Greatest Showman, and when the bearded lady starts singing, like,
You
I'm
like
just like,
This Is Us, don't you?
I mean, I'm not saying that ever happened or anything, but here's a bearded lady singing like, "This is rain, this is," and you're just bawling, and what the heck is going on right now? Like, what's happening, right? Like, you're recalibrating, and like that's a great scene, and you're allowed to have this emotion about that moment. But I remember who I was and like how I was. And I'm
Mm.
like, why is this thing making me cry? And I feel like I'm all jacked up. You know, you're having a human moment.
Right.
Let yourself have the human. Listen to what that moment's trying to share with you.
Side note, we did just watch that probably in the last 2 weeks, and it is really good.
It is good, isn't it? It's a
Really
pretty good
good.
movie.
Oh, that's funny. Dude, what do you got going on the rest of the day? Going to work?
Yeah, I got some clients lined up right after we're done here for today, and then tonight's my wife's night. I mean, we try to make sure every as much as we can, once a week, we try to give each an opportunity to go and do like give each other time to miss one another. So
Mm.
if I can give her an hour and a half or 2 hours to go hang out with friends or participate in, like, she's going to a church group tonight, and I'll take the kids, and, like, she provides me the same opportunities. I mean, even if I saw a horrible movie, first thing I want to do is go back home and complain about how bad the movie was, because, like, that space allowed me, like, we have to create opportunities to miss each other.
Yeah. No, that's good. That's really good. I like that. Anything you want to say before we wrap up, man?
I don't know, man. Let's leave it at a question for for each other and for other people, anybody that might be listening too. This is one that I got asked not that long ago, and I've had fun thinking about it. But what do you want to exist even if you don't?
Say it again.
What do you want to exist even if you don't?
I like it.
Something to chew on, something to think about. I think it helps us kind of prioritize what we actually value, like what matters to us, and maybe even recognize things that we thought we valued that are not that important because it doesn't make the list.
That's good. Well, dude, I appreciate your time. I'll let you roll. We got to do it again.
Yeah, man, absolutely. I love it. It's a good
All
time.
right. Thanks.
All right, buddy.
Thanks for watching. Please like, comment, and subscribe. And please share this content with anyone you think it will be helpful with.